We talked a bit about using some cancer examples to really as a way of discussing cancer prevention and tackling obesity in your practices as a very active form of cancer prevention. Perhaps the new smoking prevention is obesity prevention. But now what we want to talk about is that teachable moment. The patient who's sent back to you by me, I've said I've finished all their adjuvant treatment, they've had their surgery, and you're now going to be taking over their care in terms of their cancer follow-up. But it may also be that there are some other important issues to review. So Kerry's going to introduce our first case.
Thanks very much, David. So I'm going to present this case, and again, this was a case that actually came from Dr. Liz Hovey, and thank you very much for the notes, and I've tried to put this together from a GP point of view. So this is Russell. He's 61 years old when he first presented in July 2006. He presented to his GP with some urinary symptoms, poor urinary stream, terminal dribbling, and noted at that stage to have a mildly enlarged smooth prostate. Nothing terribly suspicious, but they did a PSA. It was slightly elevated at 6.2, and he had a true cut biopsy of his prostate, which showed that he did have prostate cancer. Adenocarcinoma, mostly in the right lobe of his prostate, with a Gleason score of 5 plus 4 equals 9, so quite a highly aggressive score here. Understand the maximum is 6 in each of those grades. So the first line of cells was 5 out of 6, second line was 4, so his total score was 9. He's a school teacher, unmarried, living with his sister, and he'd been battling with obesity for the last 30 years with gradual increase in weight in the last 15 years. His weight at presentation was 130 kilograms. Height was 1.7 meters, his BMI was about 45, so he was classified as morbidly obese. He had a number of other chronic diseases, none of which is unexpected: hypertension, hypercholesterolemia, diabetes, and gout. His current medications were perindopril, amlodipine, atorvastatin, and metformin. BP not too bad, considering 145 on 90. Total cholesterol also fairly well controlled at this stage. And his HbA1c remarkably good for what's going on here. A non-smoker, but drinking 4 to 5 standard drinks a day. And interestingly, this really only came out in the notes that I saw, quite substantially further on. But from that history, it seems that at presentation, he probably was drinking this amount of alcohol at the time. His absolute cardiovascular risk, based on the fact that he's diabetic and over 60, is already above 15%. But some of those risk factors probably moderated slightly with his blood pressure under control and his cholesterol under control at the moment. All right, so after this biopsy, he had a CT scan and a whole body bone scan. His CT scan of abdomen and pelvis showed, again, not surprisingly, fatty infiltrate of the liver, a non-specific portohepatic node, which was thought to be non-specific, and no bony abnormality, and the whole body bone scan, widespread degenerative arthritic changes, and again, not surprising given his age and his weight, and no evidence of bony metastases. So at that stage, what they thought they were dealing with was a high-risk prostate cancer with a Gleason 5 plus 4 equals 9, and a high risk of extracapsular spread, but no current evidence of metastases. The treatment plan at that stage for his prostate cancer was that he was not for surgery, and from what I can gather, partly because of possible positive margins, and although it's not written there, I think maybe one of the reasons they decided not to go for surgery was the high risk of a radical prostatectomy in someone who's morbidly obese. So the decision was made for hormone therapy and external beam radiation. He started initially on Androcure or Ciproterone, one of the anti-androgens, and he was started on Zoladex or Goserelin injections. The plan was that they would be 3 monthly until at least 2 years after his radiotherapy. That was to be initiated, and then he was to start radiotherapy 4 months after that androgen therapy had started in January 2007. Now, as you'll probably note, he has a considerable amount of obesity-related comorbidity, the hypertension, the hypercholesterolemia, the diabetes, the fatty liver, which we picked up on the CT scan, and the osteoarthritis. But he has some obesity-related oncology treatment issues, one of which was the fact that the radiotherapy machine has a weight limit of 130 kilograms. And the radiotherapist was also very concerned about increased skin reactions because of weight-related skin folds. And as I said, the concern about a radical prostatectomy being even higher risk because of his weight. So I'm going to ask a couple of questions as I go through, but I think we're going to right through to the end because we're going to concentrate more on his post-treatment. But one question here that I would like to address to Liz and others is, does obesity increase the incidence or aggressiveness of prostate cancer? But let's go on. So with that treatment, with his anti-androgen therapy and his radiation treatment, his PSA dropped to below 0.1. By July 2007, it stayed that way for 2 years. He did very well. But in April 2009, it started going up again. And at that stage, they started him on Coscidex, which is bicalutamide, an androgen receptor blocker. Don't worry, I had to look these up. And his PSA dropped again to below 0.1. And he did well for another 2 years. He started developing significant obstructive symptoms, and by May 2011, the urologist did a transurethral resection of his prostate. But from the notes that I could see, at least by June, the PSA was increasing again. His whole body scan, bone scan at that stage, 2 possible bony metastases, but not confirmed on a later scan. And at this stage, I think he was classed as castrate resistant. The Coscidex was withdrawn, and they sent him to the medical oncologist to consider palliative chemotherapy. A lot of problems between July and October 2011. He was noted to be depressed and morose and not talking to his sister. His diabetes was not well controlled. His HbA1c went up. And I saw on the notes now, this is now 4 years into his treatment, his weight has ballooned up from 130 kilograms to 147. That's a 13% increase in body weight. He was complaining of some right hip pain, thought at that stage to be worsening osteoarthritis. Second question that we're going to put at the end is, what effect does androgen deprivation therapy have on weight, diabetes, and cardiovascular disease? Well, so what happened then, in fact, he was seen by an orthopaedic surgeon who felt he had significant osteoarthritis in his hip and that he might benefit from hip replacement. That was booked for early 2012. And he was referred to the lifestyle clinic for an exercise program and referred to the dietitian. This is what happened with that referral, and this is 4 years into his treatment, 4 years after he's finished his treatment. He managed to decrease his alcohol intake, and this was the first time I saw in the notes that there was a comment about his alcohol intake. They were concerned about it. He managed to decrease it to 1 beer every 3 to 4 days, and he managed to lose 7 kilograms. He had a 5% decrease in his weight, even with significant right hip pain, and improved his mobility and his strength. And his blood glucose profiles improved. And my question here was, shouldn't he have been referred to the lifestyle clinic and the dietitian in 2007 when he was weighing 130 kilograms? And would that have actually made a big difference? By November 2011, however, he had multiple bony metastases noted in his skull, ribs, sternum, vertebrae, and pelvis. He started on a trial with a novel chemotherapy drug, but by January it was obvious that wasn't working, it was progressing. He pulled out of the trial, he changed to docetaxel. The hip replacement was not done, I presume because of the extensive bony metastases. He was complaining of worsening urinary incontinence. He had a repeat TURP and a urethral sling, and unfortunately during that it was complicated by a major rectal tear, and he finished up with a permanent colostomy. It was thought that maybe some of these complications were also due to the difficulty of doing surgery in somebody who's so obese. 2012, increasing incontinence and hematuria, permanent indwelling catheter, recurrent UTIs, repeated admissions, several interruptions to his chemotherapy, worsening bone pain, seen by the palliative team, started on OxyContin and Endone, and at this stage he lost some weight to 124 kilograms. But by late 2012, increasing falls, poor mobility, admitted to a hospice and then to a nursing home. He was under the care of the GP and the palliative team, and he passed away in May 2013. So these were the 3 questions that I asked as we went through looking at. The first one, does obesity increase the incidence of aggressive prostate cancer? or the incidence or the aggressiveness of prostate cancer. Second one was, what effect does androgen deprivation therapy have on weight, diabetes and cardiovascular disease? And thirdly, what difference could we have made if he'd got to the lifestyle clinic in 2007, considering in 2011 when he was actually with metastatic disease and really in big trouble, he managed to lose some weight and do well. So, over to you, Les, and to...
All right, we might ask the other members of the panel as well, each of whom will have some perspective on this. So Greg Robertson will be more for the second case, but please come up talking in general about surgical issues and weight. Jennifer Olding again.
Is this one working?
Introduction, and Jerry Green.
This one doesn't seem to be working. Have I just not turned it on? Is it coming through there? Okay, we can give it to the panel.
So before I answer can you hear me? Before I answer these questions, I'll just maybe have some comments about this chap who did sort of remain in my mind some years after his passing. So he was quite young when he sort of originally presented, around 60, 61, which is about sort of 10 years before the median age of onset, and it was a Gleason 9, which is a high risk and aggressive. As Kerry sort of mentioned, his upfront treatment was impacted by his obesity. I have no doubt that the urologist's decision to refer him onto the radiation doctors had, in a major part, they're not normally that scared of positive margins. I think it was, certainly due to his habitus. And then it was interesting that, had he been a few kilos higher at the time, as the radiation machine had a limit of 130 kilos, I mean, he almost missed out on that as an intervention as well. So certainly his obesity was impacting on his osteoarthritis. When he had the ADT, ADT can increase things like dysphoria, mood issues. He certainly had all of those.
Sorry, what's the ADT? Just tell us what
androgen
is.
Deprivation therapy. Sorry, so that includes the GnRH agonists such as Zoladex, which he was on, and the anti-androgens. And certainly the androgen deprivation therapy also made it harder for him to keep his weight down, and I think that his obesity ultimately impacted on his performance status, which, as we all know, impacts on cancer prognosis and can also interfere with the ability to exercise, which is a very positive intervention in many solid tumours, including prostate cancer. And also there's a possibility that rectal tear he had when he had the urethral sling operation to help with his incontinence, that's also, and Greg might want to comment, I mean, to sort of move all his fatty folds and so forth, and, operations are much more difficult in someone who are obese, and it was obviously an unintentional rectal tear, so he ended up with not only a permanent catheter, he also ended up with a colostomy, and he'd actually gone in to help his urinary incontinence. So he certainly had lots of things that were sort of intertwined, although, as Kerry said, there was that period where he was incredibly motivated at the UNSW Lifestyle Clinic and did manage to improve his mood, lose some weight, and improve his sort of diabetic and lipid profiles during that time. So I don't know if you want to sort of say anything about the difficulty of operating in people who are sort of 130 plus kilos.
I'm not sure this is working, but
it's going through to the...
The biggest problem there also, not as the obesity, is the radiation. Radiation's an absolute mongrel to go back operating with. Anything goes wrong, it heals poorly. So that would have been a double whammy.
It's
not working.
Okay. So we might.
I can start with the questions.
Go through the questions.
So, in terms of the first question, does obesity increase incidence or aggressiveness of prostate cancer? The answer's yes, although it's a bit of a complicated answer. And in actual fact, there are quite a few studies which have sort of said that obesity doesn't increase the incidence. And the actual answer is a little bit more complicated than that, because it's a mixed picture depending on the grade of the actual tumour. I've got some hazard ratios here. So there was one really good study with over 10,000 patients that showed that if you were obese, that decreased your risk of low-grade prostate cancer by 18%, but increased your risk of high-grade prostate cancer by 29%. And if you were looking specifically at the high end of the Gleason 8 to 10, it actually increased your risk of aggressive prostate cancer by 78%. But when there have been other studies that didn't account for the grade, so some studies you don't see the actual association. But I think now it is established that obesity increases your risk of high-grade aggressive prostate cancer, also increases your risk of prostate cancer-related mortality, also increases your risk of biochemical recurrence after either prostatectomy or external beam radiation, and also increases the complications you experience on androgen deprivation therapy. So I think that's really been answered now.
So that's question 2 that you're referring to then?
No. This was about... right, so yes, I'm sort of moving into that as well. Yeah. So in terms of what does androgen deprivation therapy effect have on weight, diabetes and cardiovascular disease, again, there's lots of different studies with different sort of hazard ratios and so forth, but it's definitely now there's a huge amount of literature showing that you increase your risk of diabetes. The hazard ratio is anything between 1.28 and 1.44. It also increases your risk of all coronary artery disease, but a more modest hazard ratio, like 1.11. It increases your risk of sudden cardiac death, and it increases your risk of an actual heart attack as well as ischemic heart disease. So I think all of those are, and in non-cardiovascular issues, it also looks as though it probably increases your risk of acceleration of things like dementia as well. So that said, generally there's more benefit than harm in most of these patients with prostate cancer to intervene with the androgen deprivation therapy. But you really have to tailor it as to who you give androgen deprivation therapy to. So, for example, there's quite a few Me Too drugs out there in that space. There's not only LHRH agonists, there's now LHRH antagonists. So many of you might have patients who are on Degarelix or Firmagon. So that particular company is sort of touting there's one meta-analysis that shows you've got less cardiovascular morbidity if you use the LHRH antagonist with Firmagon. So there's all sorts of things that are being looked at and being raked over. But certainly it's incredibly important when you put someone on androgen deprivation therapy, not only do you have to think about their bone health and get a baseline bone mineral density, you also need to think, have you optimised their cardiovascular health? What's their waist to hip ratio? Do they need to see the dietitian? And we'll talk to Jennifer in a moment about that. So you need to sort of think about all of those things, and sometimes it's important for them to maybe see the endocrinologist or the cardiologist before you get going. Sometimes the benefit-risk ratio really tips more in one direction than another. So, for example, I've got a few demented patients or early memory loss where after long discussion with the patient and their family, and particularly if they're asymptomatic from their prostate cancer, they're maintaining their weight, they've got no bone pain from their bone metastases, we might not put them on androgen deprivation therapy. So it's a really patient-by-patient decision, and you have to sort of talk about all these effects with them.
Can I bring Professor Greenfield into this? I'm sure you must have had some prostate cancer patients with these kind of problems and how you addressed it.
Yeah, I don't think this is working, but I'll just talk into it anyway.
Well, they're saying it's working for the recording.
Okay, fine. All right.
Yeah.
So we certainly see patients on androgen deprivation therapy, and as you mentioned, their bone health is of key importance, and most of the patients will lose bone, so they'll need some sort of anti-resorptive therapy, but they'll often gain weight, they'll have low testosterone levels, they won't feel like exercising, that'll contribute to their weight gain. They'll increase body fat, particularly visceral fat, and their diabetes control usually gets worse. And as you say, there's a high risk of coronary artery disease and cardiovascular disease. So we certainly will see the patients, if they have diabetes, their control usually gets worse, and therefore will need to augment their anti-hyperglycemic therapy. If they've got prostate cancer, you actually might want to specifically avoid drugs such as the SGLT2 inhibitors because they work as glycosuric agents, and the patients will have an increased risk of urinary tract infections and thrush, and particularly if they haven't got a good urinary stream, etc., or some retention, you probably want to avoid those medications.
Short of diabetes, the other thing I didn't mention was sort of dyslipidemia increases on androgen deprivation therapy, and also, here I can move all that off, and also increased risk of insulin resistance as well. So people who might not get overt diabetes, certainly they can get metabolic syndrome.
Yeah, and definitely. And I think dietitian involvement and is obviously key at that time, but we certainly keep an eye on their metabolic profile, and we might be using agents that help promote weight loss, as we mentioned in the other session.
Segues quite nicely into dietitian now.
So the question is, should he have been referred for lifestyle advice sooner? Is that what you mean?
No, well, just about the kind of diets you recommend for people on
Once they're on
androgen
ADT,
therapy.
what you were thinking.
Yeah, what would you do?
I'll do please.
I've got no involvement with that. Yeah, we wouldn't get referred someone for being on androgen deprivation therapy. We might have someone referred for lifestyle advice, for assistance with controlling their diabetes or their hypertension. But yeah, the dietitian sort of doesn't go as deep as understanding specific medications which might need treatment.
Oh, I guess the question's a bit different. Dr. Hovey sending a patient to you saying, I know that this patient on ADT is going to get more weight problems, more diabetes problems, and a high risk of cardiovascular disease. How are you going to counsel that particular patient that might help them reduce those risks?
It would be through lifestyle advice, the 5 A's, the Australian Guide to Healthy Eating, eating from the 5 food groups, controlling their weight, exercising, basic lifestyle principles. Yeah.
So I think Brianna,
Brianna?
quite
Yeah.
a lot of work about exercise and prostate cancer.
I think
Brianna,
we're
take that.
very, well informed on this particular front, but certainly there's a lot of evidence to suggest that exercise is not only safe but very effective in maintaining bone density for people who are on ADT, as well as tackling a lot of the cardiovascular and metabolic complications that come with that drug.
And mood as
and
well.
mood, absolutely, yeah. And I think that you mentioned as well that, you know, often they're in this position where they don't feel particularly like exercising, but actually a lot of the research has shown that once men are given access to these kinds of programs, that they benefit enormously. In this particular case, there's also a bit of a question about that prehabilitation phase. Maybe that would have been a good time as well for...
Yeah, so in my defence, I met the patient, you know, at the time that he was referred to I referred him to the UNSW Lifestyle Clinic. I pretty much refer everyone that I think needs it immediately. But I think we do probably need to chat to our surgical and radiation oncology colleagues just to kind of have that more front of mind. Prue Cormie, one of your exercise physiology sort of colleagues, has written extensively in this area, and they've done lots of interviews with patients who undergo exercise programs, and there's, as you say, very high acceptance. They really like the peer support. They really, really like the group activity, and it really helps with their self-esteem as well as their sleep quality as well. And their body image, definitely. Because, you know, sometimes I've had men, you know, on androgen deprivation therapy who say they no longer feel like a man. You know, I've had some very sad men, you know, but, you know, particularly in the metastatic setting where they've definitely lost their libido and ability to have sex. Their whole self-image is really rocked by it. And an exercise program, as well as sort of counselling and psychological input, can be absolutely important.
Thank you. Considering the complication of androgen deprivation, do you think surgical castration would have helped him?
So interestingly, there are some studies which look at whether bilateral orchidectomy has got a different side effect profile to the LHRH agonists, and most of the studies are contradictory. So one of the studies I looked at said that if you do a surgical castration or bilateral orchidectomy, the risk for diabetes is there, but less cardiovascular risk. But then there was another, I think, Canadian study where the cardiovascular risk was just the same between surgical castration and medical castration.
It does not have a negative effect on the weight.
the particular set of studies I looked at didn't differentiate in the weight question between surgical and non-surgical, but I mean it's plausible. Perhaps I don't know if you've got any comments about that, Jerry.
I'm not sure that they've looked at that in that much detail, and also it's key to look at whether you gain visceral fat or not, because that's going to be the one that's going to predict your risk of diabetes and cardiovascular disease. I'm not sure the studies have really drilled down that deeply into those things. But just one other quick comment is metformin is, I think, really important drug in this situation. If someone doesn't have diabetes or has pre-diabetes in particular, that might be the thing you need to keep them progressing into becoming diabetic and developing hypoglycemia. And also it might have some benefits in regards to their prostate cancer, although I understand there are a number of studies going on. One of the big flaws, not flaws, but one of the key things I think with all of these studies that it's important to look at is to look to see whether the patients at baseline have a degree of insulin resistance. Because in theory, metformin may be beneficial if the patient is insulin resistant, but not if they're insulin sensitive. And potentially some of the negative studies that have come out in this regard might actually be confounded by the fact that everybody's lumped in together and they don't distinguish between, say, an insulin resistant and a sensitive subject. We know metformin has its greatest benefits in insulin resistance.
Yeah, the pendulum is really swinging about metformin. So with diabetes being less common in obese patients, obesity was protective with regards to diabetes in that particular setting. Some researchers have wondered whether or not it's the diabetic medications which are protective like metformin, and that's what's led to a lot of this research with metformin. And I think there are metabolic advantages of being on the metformin, but in terms of the anti-cancer activity, that's a real pendulum, and there's a lot of preclinical work that looks that the combination of metformin and simvastatin might be interesting. So there are a lot of patients around Sydney who don't want to be on hormone therapy who are on that combination of metformin and simvastatin. But interestingly, at GU ASCO, which is one of our conferences, there was a recent presentation with a metformin intervention which was profoundly negative. So so I think in terms of its anti-cancer credentials, I think we've still got to really wait for some more ongoing sort of study results.
Any other questions from the audience on this case?
Because we need to wrap up with this one, I think.
Did you need to say something?
Danielle?
Oh, sorry.
What oral agents would you consider as appetite suppressants to help this gentleman lose weight?
Well, I suppose any of the agents that we've got could be useful. We talked in the small breakout sessions about Duramine or the GLP-1 receptor agonists. They are very reasonable drugs to use in this situation. As I said, I'd avoid weight loss drugs such as SGLT2 inhibitor, but any of the GLP-1 drugs and also Duramine would be very reasonable, and there's a new medication called Contrave that could be used. So they're all very reasonable drugs.
Okay.
Just one last quick comment. I think in regards to the prostate cancer and the negative trials, I think it is, it would be nice to look back at all of that data to see whether insulin resistance determines the response and whether there's a benefit. And I suppose in regards to Liz's point, I suppose the point you were making is that if you think about first principles, if you've got an obese patient who's insulin resistant, their SHBG is low, their testosterone is low, you might predict that the risk of prostate cancer might be lower than the general population because they've got lower total testosterones. And I suppose what you're saying is it might actually be the metformin treatment that they're on that might be confounding that association and nothing necessarily to do with their diabetes. Yeah,
I don't think I said that clearly before. So in diabetics, there's actually less risk of both low grade and high grade. But as Jerry says, it could be there's a lot of confounders that could possibly be in there.